Hello, this is Derek Angus speaking from Pittsburgh, and I'm here with my colleague Howard Bauchner from the Chicago office of JAMA, and both of us work at JAMA. I work for Howard. Howard is the editor-in-chief, and I'm the associate editor for critical care. And on behalf of Howard and I want to say it's a delight to be here. We love working with ESICM. This has been an incredible session so far today, and we look forward to bringing you three great speakers over the next hour. Howard?
So just a couple brief comments. It is a privilege to be here. I want to thank Joseph and Maurizio, and I wish all of my colleagues around the world, particularly intensivists, other clinicians, the best, and that they still stay healthy. It's rare in your lives that you get to participate in the care of so many ill patients and save lives on a daily basis. And my respect for the discipline and for all of the healthcare systems around the world is immense. One or two brief comments before I introduce Preeti. People often ask. We're getting about 100 submissions a day. All of the research letters go to Jody Zelke. I review all of the viewpoints, original investigations, brief reports, and along with Derek, Eli Prevenovich, Gordon Rubenfeld, and Preeti, as well as the senior staff, help make decisions about which papers will go forward. It's been an extraordinary opportunity. The JAMA content has had about 25 million views over the last 2.5 months. A number of our articles are well over the 1 million views, and the live stream that I did with Maurizio has close to 1 million views, and as I've said before, both privately and publicly, I think galvanized the world around this pandemic. I think people recognized it was going to be a huge issue, and I think that live stream video, as much as anything else, convinced the world that we were facing an enormous crisis, particularly in critical care. So with that, I'd like to introduce the first speaker. She's a friend and a colleague. It's Preeti Malani. She's a professor of medicine and infectious disease at the University of Michigan. She's our associate editor in infectious diseases. She also edits the Peace of My Mind section. And then finally, she's also chief health officer for the University of Michigan and is advising the president of the University of Michigan about how to bring 50 million or 50,000 students potentially back to the campus in the fall. So a great deal of experience and a great deal of responsibility. Preeti.
Thank you so much. Thank you, Howard and Derek, and also thank you to the ESICM organizers for inviting me to this special virtual half marathon. It's probably the best kind of half marathon. I'm proud to represent JAMA as an associate editor and also to represent the University of Michigan, where, as you heard, I'm a professor of infectious disease. If I were to give this talk a month from now or even a few weeks from now, it would undoubtedly look different, which is a reflection of just how fast things are moving in the treatment arena. At the same time, we really are not sure that the treatments we are using in severe COVID infection are in fact effective and safe. And everyone is waiting on better and more definitive data, especially from large multi-center randomized clinical trials, which are fortunately, many of which are underway. I'd like to set the stage with two viewpoints that take a broad approach on this need for evidence for therapies and guidelines. The first comes from Dr. Andre Khalil from the University of Nebraska, and it's titled Treating COVID-19. Yes. My what? What is out? Oh, it's not out? Oh, I'm sorry. Let me see if I can apologize. Okay, is it on now? Okay, thank you. So this first viewpoint is treating COVID-19 off-label drug use, compassionate use, and randomized clinical trials during pandemics. And Dr. Khalil reflects on that essential need for randomized clinical trials and treatment for really any future outbreak. And he makes several important points. The first, he talks about the 2014 Ebola outbreak, which basically all the studies were done without concurrent control. So in the end, we really didn't have any definitive conclusions regarding efficacy or safety. Second, many of the drugs that are looked at look promising in vitro, but then when they are in clinical studies, they've failed. And third, and this is very important, is compassionate use therapies that have not previously been approved, for example, remdesivir, could have serious adverse effects that were not previously identified. And he concludes by saying the rapid and simultaneous combination of supportive care and randomized clinical trials is the only way to find an effective and safe treatment for COVID-19. The second viewpoint actually comes from Dr. Derek Angus, as well as Dr. Francois Lemontagne, and this addresses the Surviving Sepsis Campaign guidelines, which of course the audience is very familiar with. This is the management of critically ill adults with COVID-19. It was initially published in March. And those guidelines remarkably had 50 or more recommendations under 4 domains and created a concise summary of the evidence. It also helped to reduce variation in clinical practice very early in our experience. But it's what's not in the guideline that's important for today's discussion. And the authors write implicitly, the guidelines also suggest the need for specific research effort. In 6 instances, the panel makes no recommendation because evidence was deemed insufficient. In other instances, the panel issued weak recommendations for or against specific therapies. And again, this viewpoint highlights those gaps and the importance of them, which brings us to the research articles that I'd like to briefly share. And for this format, I'm going to stick with just showing some key figures and talk about some of the key findings since our time is so limited. I would like to remind everyone that all of the coronavirus-related content across the JAMA network is available free without paywalls. It is at jamanetwork.com. And before the talk this morning, I also took the opportunity to tweet out the links for all these articles. So this beautiful figure comes from an article by Sanders et al., and it's a review of the pharmacologic treatments for coronavirus disease 2019. And I'm not going to discuss the content except to show this figure as an illustration of the viral life cycle and really all the many potential drug targets, including non-structural proteins as well as viral entry and immune regulation pathways. And if you look closely, you'll see a number of agents that are depicted here that are currently in different stages of clinical trials. This was published in April, and it is in this week's print edition for those of you who like print, like me. The first study is from Dr. Eli Rosenberg and colleagues, and there has been a lot of interest in hydroxychloroquine and with or without azithromycin as a possible therapeutic agent for COVID-19. However, the data are limited, both for efficacy as well as for adverse events, and some of those concerns include prolonged QT and arrhythmias. And this paper does a nice job of addressing some of those issues. This is a retrospective cohort study. It's more than 1,400 patients who were hospitalized with a diagnosis of COVID-19. And this was from 25 hospitals across metropolitan New York. It's obviously an observational study, and the primary outcome the authors were interested in was in-hospital mortality. Of note, those receiving hydroxychloroquine were, as well as azithromycin or both, were more likely to have diabetes, a respiratory rate of greater than 22, abnormal chest imaging, and oxygen saturation lower than 90%. So these were patients that had more severe disease, and they were at baseline a little bit different. This is the table that shows unadjusted treatment outcomes, and I just highlighted one here, which is death. And overall in-hospital mortality was 20.3%. And the unadjusted death rates were higher among both patients who got the hydroxychloroquine as well as the azithromycin and hydroxychloroquine, and hopefully you can see those. The adjusted data is important to look at, and this is a Cox proportional hazards model. And this was adjusted for demographics as well as pre-existing conditions and illness severity. And when that was done, compared with the neither drug group, which is sort of in the middle here, none of the 3 treatment groups had statistically different rates of death. So there was not a mortality difference, and there also wasn't a higher rate of death in treatment. So I just wanted to show this because I think this is, for me as a clinician, this is very important. This is the adjusted logistic regression models, and compared with patients receiving neither drug, cardiac arrest was significantly more likely in patients receiving both drugs, hydroxychloroquine and azithromycin, and the adjusted odds ratio was 2.13. This was not seen in the drugs used individually. And again, this is just important to note, this observational study, and hopefully we will have more data on this to guide this. There were not differences noted in abnormal EKG findings. And the authors conclude that among hospitalized patients with COVID-19, treatment with hydroxychloroquine, azithromycin, or both, compared to neither treatment, was not significantly associated with differences in in-hospital mortality. And the lack of observed benefit, it's consistent with what has been seen in other observational trials. Now, the clinicians were waiting on the randomized trials, and there are multiple going on, including the ORCID trial, which is of interest to this group, as well as the HERO trial, which looks at post-exposure prophylaxis. So the story is not done, but I know that at my center, we're not using these drugs outside of clinical trials. I did want to go on to this article, and I really like this article a lot. This is from Shen et al. This is a preliminary communication. It's a case series of 5 critically ill patients with COVID-19 who had laboratory confirmed disease, and they were treated in Shenzhen, China, using plasma from individuals who had recovered from infection. And when this was published, which was on March 27th, which seems like a long time ago now, this was the largest and really best described experience to date. And I still feel that there are a lot of really nice details in this paper. Certainly the use of convalescent plasma is not new. In fact, it's very old, but there's a lot of new interest in this modality. There was interest in this during Ebola, as well as during SARS-CoV-1. And that interest has been rekindled as a therapy for severe COVID-19 infection. And again, this was 5 patients, and they're shown here in this table. They all had severe respiratory failure. They had ARDS. They were mechanically ventilated. One of the patients was on ECMO support. And as you note here, 2 of them also had concurrent bacterial and or fungal pneumonia. These were patients who had been in the hospital for quite a while, and they were quite ill, not unlike the type of patients that many of you see and that I see on a regular basis. 4 patients that did not have coexisting medical conditions, they received the convalescent plasma around day 20 of their hospital stay. And the 5th patient, who did have some underlying hypertension and mitral insufficiency, received it on day 10. The donor plasma was shown to have IgG and IgM, anti-SARS-CoV-19 antibodies, and neutralized the virus in vitro culture. All 5 patients recovered, and their clinical status improved around 1 week after transfusion. And the use of convalescent plasma may or may not have contributed to this recovery. Again, it's hard to say since it's such a small number, but this figure is also a really nice figure, and it represents some very clinically relevant endpoints, including the SOFA score, which came down over time, the PaO2 to FiO2 ratio, which improved, and of course, body temperature with fever, which resolved. And this panel A looks at the cycle threshold, which is a measure of how much virus can be detected on nasopharyngeal swabs. A higher threshold means less virus. So this was also moving in the right direction. In addition, the patient's neutralizing antibody titers increased after transfusion. Again, small numbers, but you can see that the IgG, IgM, and neutralizing antibody titers all did increase. In the United States and really around the world, the use of convalescent plasma for COVID-19 is really increasing. The interest is increasing. This is an investigational product in the United States. It's not approved by the FDA. And there's growing interest in this. We are mostly using this in the setting of very severe infection in patients who are critically ill. But there's also some interest in using this as prevention in high-risk essential workers, including healthcare workers. We really don't know much beyond anecdotes at this point. And within the past couple of days, there were safety data on 5,000 patients that was placed on a preprint server. This was interesting because overall it showed pretty good safety. There were a few deaths that may have been related to the transfusion. But again, this is where that randomized trial data is going to be interesting, and just better, bigger studies will help guide hopefully when and how to use convalescent plasma. This is not a manuscript, it's a press release. And I know everyone has seen this and everyone's waiting for the full study to be published, but it's an example of preliminary results that were initially presented in the popular press and social media, not as a published manuscript. This is a reflection of where we are with COVID, that things move so quickly. But it's also a reminder that speed is good, but details are better, especially to make thoughtful choices around clinical care. And around the United States, remdesivir has been really very high on our minds, including some difficulties getting access to this drug and trying to figure out how it's distributed. My hospital does have dosing for several patients, and we have created some criteria around how to allocate this. Much like the hydroxychloroquine a month ago, this has gotten so much attention that we are seeing patients present and their families ask about the use of this drug. And I'm going to end with this viewpoint that's written by two of my favorite people, my mentors at JAMA, my friends, including Dr. Howard Bauchner, who is moderating this session, as well as Dr. Phil Fontanarosa. And I would just, in the interest of time, I would encourage all of you to read the full viewpoint. It's beautiful. Every word of it is powerful. It includes a number of suggestions for encouraging investigators to really move the science. And one of the suggestions is for investigators to share patient data if they are working on similar trials with one another, even if the analysis of the combined data is not pre-planned and would be considered exploratory. Another important message that I really like and that resonates with me is that treatment is treatment. And even if treatment trials show efficacy, treatment is not prevention. And so we do need to consider prevention. I will leave you with this beautiful sunrise from lovely Michigan. This photo was taken near my home. This is the longest couple months that I can remember. And I know it's been even longer for all of you who are on the front line in critical care, intensivists, my pulmonary colleagues. And it's going to unfortunately be this way for a while. I want to thank you for everything that you've done for our patients, really for our colleagues, for our communities. But I also want all of you to take a moment to take a breath and hopefully take care of yourselves. And with that, I will stop.
Can you hear me?
Yeah.
Great. So there are a number of questions, but we're short on time. But you went through hydroxychloroquine, our article. There was one in NEJM, and I think at least at this point, the data would suggest its use should only occur within a randomized clinical trial. You mentioned the NIH press release, a mortality benefit of 3 or 4% within the clinical trial. We'll see what the ultimate report shows. But the other drug that continues to get an incredible amount of attention, and I know you've used it at Michigan, so I call it TOSI because I don't pronounce drug names very well. But can you comment on your sense of TOSI?
Yeah, I call it TOSI too. So we have pretty strict criteria in the use. And again, I think it's if you ask us, we'll say, oh, it seems to work. But again, I think it's a selection of who we choose to treat. We work closely with our critical care colleagues to try to get at patients, again, before they're intubated, before they have decompensated clinically. And we're treating people that we feel, whether it's right or wrong, are more likely to do better, and limiting treatment in patients who maybe are not going to do it quite as well. But it is interesting. It comes with a cost, not just a money cost, but the risk of pneumonia appears to be higher. And that's been seen in observational data by other places too.
Thanks, Preeti. I'll just make a final comment, and then I'll turn it back over to Derek. We have gotten between 5 and 10 papers, observational studies, small case series of 25, 50, 75, with respect to the use of toci. And all of them have been rapidly reviewed internally, and none of them have made it to publication, in part because of the imbalance of who's getting the drug and who isn't. And in many of the studies, virtually all of them, what our statistical and methodologic reviewers have indicated are implausible effect sizes. And so, you know, Derek and you and Gordon have participated in those discussions. So every Wednesday, we review the most recent original investigations that have come in. And despite my wanting to go ahead with one or two of them, I've been persuaded that they're not the best studies to publish in JAMA. With that, Preeti, you've been fabulous. Thank you for everything, and I'll turn it over to Derek.
Yep, thank you, guys.
Bye, Preeti.
Bye.
Thanks, Preeti. And yes, I would just echo that. It's really, really hard to tell whether drugs like toci are going to work based on observational studies. So hopefully we'll have some good RCT evidence in the coming weeks or months. So let's pivot to another aspect of critical care, and that is to think about how to manage the respiratory failure that accompanies patients in distress with COVID-19 disease. And it's really our delight to invite someone incredibly well known already to the ESICM community, Laurent Brochard, originally in Paris for many years, but of course in the last few years has been the director of the incredibly well-known sort of interdepartmental division of critical care at the University of Toronto. He's a former editor-in-chief of intensive care medicine. He's a long-standing associate editor at the Blue Journal, and he's really one of our preeminent experts in respiratory failure, both under non-invasive and invasive settings. And I couldn't think of a better person, a perfect delight for me to invite my friend and colleague, Laurent Brochard, to speak on the really interesting question of prone positioning in patients with COVID-19 who are still spontaneously breathing and not necessarily intubated. So Laurent, over to you.
Okay, thank you so much. Thank you, Derek. Very kind introduction. Thank you both, Howard and Derek, for the invitation, and to ESICM. So I'm very happy to discuss about a couple of studies which have been published in the JAMA about this question of prone positioning during spontaneous breathing. So as a way to treat or to prevent, as already been discussed, the outcome of respiratory failure. And this is an editorial we wrote with Irene Telias from Argentina and Bhushan Katira, who is a pediatrician in Toronto. So the question was, is the prone position helpful during spontaneous breathing in patients with COVID-19? I have to say, JAMA has published a lot of information about COVID-19 and really nicely tried to adapt to this incredibly challenging situation. One of the interesting recent clinical update was, it's called like that, it's from John Marini and Luciano Gattinoni, and I think it has been, a lot of attention has been paid to this paper. I'm not going to go into details, but it describes what they think could be an interesting management of COVID-19 respiratory distress. One thing I was a bit surprised was that they used a new acronym, was that they say, okay, let's call this patient CARDS. But then I looked back at the literature and I saw that the guy who discovered ARDS, Tom Petty, said in the CARDS was ARDS, so that's fine. So one thing they mention in their paper is that it may be possible to use awake prone positioning as a respiratory support options. And I have to say there have been some studies already published on this issue out of the COVID-19 epidemics. but really very few data. So it's very interesting to look at these studies, which are small studies, which have the limitations of studies done in urgency, but which give nice information. So the first letter from Milan, Dr. Sartini and colleagues, gives very impressive result. You see the nice figure here where you have the change in SpO2, the change in PaO2 over FiO2, and the respiratory rate change. Importantly, this is during non-invasive ventilation. So these are patients who have been already on non-invasive ventilation for 1 week. So this may not apply to every patient arriving in your emergency department, ICU, or on the ward. And the question was really, does it improve the efficacy of non-invasive ventilation? And from this data, we would tend to say, yeah, it looks really nice improvement in oxygenation, which is consistent in terms of SpO2 and ABG, but also an interesting decrease in the respiratory rate. And why this is interesting, because you may think that even if you don't change the amount of work of breathing performed per breath, if you breathe less per minute, the total amount of oxygen consumed by your respiratory muscle may go down. But we are not sure exactly whether this is specific to NIV and what were the NIV settings. There's another paper which is maybe, I would say, probably more realistic compared to what we may observe in the clinical setting, from a French group from Aix-en-Provence and Marseille with Laurent Papazian. And you have here the PaO2 before, during prone positioning. Again, it's a non-intubated awake patients being voluntary to do the proning. And you see that the response is not that spectacular and not consistent. So they called patients responder, non-responder, and a few of them, only 4 of them, it's again a very small series, are persistent responder, which means after coming back to the supine position, they keep the improvement in PaO2, FiO2. So just to summarize, the 24 patients who agreed to participate, 4 did not tolerate prone positioning for more than 1 hour, and in fact were intubated in the following hours. 5 tolerated from 1 to 3 hours, and 15 tolerated for more than 3 hours, which is encouraging because it's a majority of the patients. And the patients who were responder were the majority of the patients who sustained prone position for more than 3 hours. So this is what we see and what we know. So maybe I'll take a few minutes to go back to what have been described about prone positioning in classical ARDS, if I can say so. And one of the things we discovered really with prone positioning is that the major reason for the distribution of the consolidation, the injury in patients with ARDS is gravity. And when you change this force, this gravity, you change the distribution of lesion, which is quite extraordinary. So this is why people mention the lung acting like a sponge. And one interesting aspect which we have to keep in mind is that there is a very, very frequent benefit on oxygenation, which may not be related to anything else than the anatomic distribution of perfusion. So this was a nice physiological study in animals, so it may not completely be the same in men, but what you see is the distribution of perfusion when the animals are supine and are prone. And what's interesting is that in supine position, most of the perfusion is on the dependent area, which are not ventilated, so that explains a lot of the shunt. But when the animals are prone, the distribution is still predominant in the same zone, which is now non-dependent. So it's much better with ventilation. So by anatomy, I would say the gravity does not influence perfusion in the same way than ventilation, and that explains a better matching of ventilation perfusion ratio, which explains the benefit in oxygenation observed independently of any other effect like lung protection. Because the other effect we are looking for is lung protection. One interesting observation was the fact that when you put the patient, this is patient now, prone, you put the flexible part of the chest wall on the bed, and in a way you rigidify, you make the chest wall stiffer. And this helps to have a more homogeneous distribution of ventilation. So this effect may be protective for the lung. And because it's protective, you need to do it for a long time. There have been a number of studies which initially found benefits in oxygenation, but no effect on survival, for instance. And I show that because there was a meta-analysis of this study which showed that maybe there is a trend for a benefit associated with the duration of prone. And indeed, it's the study by Claude Guérin in France who decided that patients should be prone for as long as possible, and on average, it was more than 16 hours a day. And this probably is a major factor which explains this beautiful effect on mortality in patients with ARDS. So, and this was in Claude Guérin's study, the duration, you see 17 hours on average. So why would we do prone positioning in patients who are spontaneously breathing? Well, one reason may be to increase oxygenation. Another reason may be to prevent the lung, to protect the lung from possible injury. We have described that patients who have a high breathing effort and high respiratory drive may worsen their lungs, and we have called that patient self-inflicted lung injury. Of course, it's unintentional self-inflicted lung injury, if you wish, but it's the drive, the brain is so much stimulated by impaired gas exchange mechanics and inflammation that the amount of effort is generating harm for the lung because of the amount of stress and local strain in the lung. And the potential benefit of prone positioning may be, again, to have a better homogeneous distribution of ventilation, less strain, and protection from these patients' self-inflicted lung injury. So from these two small studies, it's hard to have very strong conclusion. The first question is, can prone position prevent intubation? And we clearly have no response. But although this question is essential, it's important to keep in mind that intubation is a medical decision, not a physiological state. In other words, for instance, you may prevent intubation because the numbers in terms of oxygenation look better, and the clinicians may be less prone to decide to go for intubation based solely on hypoxemia. Maybe it's a good thing, but what we really need is to understand what this technique of positioning is really doing for the patients. What we see from these small studies that the clinical tolerance is sometimes a limitation of the technique. You have seen a number of patients who do not tolerate, and of course the patient has to accept it. The physiological effects are not clarified. Do we decrease these, the stress on the lung, the regional risk of injury? And also, you know, compared to what we have seen in ARDS, are there any benefits of these very short sessions? So I would say it's exciting, it's promising, but it's still very preliminary. But it's really great that people are starting to look at this technique, because it's a technique that anybody could do, and if there is benefit, it's clearly worth exploring this technique. Thank you. I stop there and be happy to address any question.
Thank you, Laurent. That was fabulous, as I expected. So we don't have large-scale randomized trials. We have these 2 reports and a few other reports, and of course, all over Twitter, people are talking about proning awake patients on CPAP, etc. So, what would you tell someone to do if they see someone tomorrow? If someone comes into your hospital in Toronto tomorrow, are you supporting delaying intubation and doing a little bit more use of non-invasive and trying proning to see if it improves oxygenation before intubation? Or do you think there needs to be a trial? Or what would you do Sunday morning?
Yeah, good question. And I would encourage people to have as much monitoring as possible to try to understand. We, for instance, have a new technique called the electrical impedance tomography, which is a non-invasive technique where you see the distribution of ventilation in the lung. So if you could do that and watching it, this may give you information about what's the benefit. I would just be cautious about using it on the floor without careful monitoring, because as you mentioned, this may be simply delay intubation because the oxygenation looks good. So I would say, as everybody you discussed already this morning, this should be done as much as possible in the context of a clinical trial. I think it's worth doing these trials. I know of 2 already ongoing, so I would encourage people to participate in this trial. If they want to do it, I would monitor the patient as closely as possible. The information we got about the respiratory rate is an interesting one. Although during non-invasive ventilation, you may have false changes in respiratory rates, so I don't think we know enough. So 1, go into a randomized trial. 2, if you do it, monitor your patient as closely as possible, because there is a real risk of delaying intubation just because the numbers look better.
And presumably, although you discussed the 2 mechanisms that could lead, the 2 broad mechanisms that could lead to overall patient outcomes, presumably that immediate benefit in hypoxia is almost certainly because fluid distribution in the lungs redistributes while perfusion remains relatively similar. And so you get a short-term immediate improvement in a decrease in VQ mismatch, correct?
Yeah, the other effect, I didn't want to go into detail because we don't really have the data, is that the position of the diaphragm is situated dorsally, mostly the muscular part of the diaphragm, not the crural part, and therefore the way the diaphragm is working may be different in the prone position and may also affect the distribution of ventilation. But you're right, yes.
So does that mean in your mind that these patients who are having problems with hypoxia have also lost their normal hypoxic pulmonary vasoconstriction? And that's part of the problem, is that they can auto redistribute?
Yeah, I think this is one of the basic component of ARDS, that vasoconstriction is certainly not perfect. There is always imperfect pulmonary vasoconstriction. Whether it's more pronounced in these patients, I don't know. We have so much report about, one of these complicated issue with all this aspect of physiology is how rigorous you are in the measurements you do. And I've seen a lot of report about vascular effect, and which to me are not well documented yet. So I think this loss of vasoconstriction has been always described in classical ARDS. So it certainly exists here. Whether it's more pronounced, I'm not so clear. And the small reports we have about inhaled NO were not very spectacular, for instance, in this regard.
And I'm going to leave you with a final question then. So am I right in thinking that if I were to ask you the question, does prone positioning in the awake non-intubated patient help or hurt in COVID-19, you would say yes, that it might help some patients and hurt others?
Yeah, and so the other thing is that I do love physiology, of course. I think it's very important. But every time we talk about patient management, we have to deal with clinical decision making and how it's how things are decided. So it may help physiology, but be careful it does not harm the patient because you take the wrong clinical decision.
Right.
This is an easy way to respond poorly.
Okay, Laurent. So I have to say, on behalf of Howard, myself, and ESICM, as always, it's a delight to listen to you speak, to hear your wise words. Get back to the ICU. I know you're having a busy day, and we will move on to the next speaker.
Okay,
Thanks,
thank you so much, guys. Thank you very much. Thank you.
And then, Howard, do you want to introduce our next speaker, our friend and colleague?
Well, he's your colleague, so I think it best that you introduce him. But I would say Doug has tread into one of the most complicated issues that has arisen in the United States, and I suspect around the world, with enormous emotional attachment to it. And that was the concern in the U.S. that there would initially be restrictions on the number of ventilators, and they would have to be rationed. And now it's quite clear that drugs may need to be rationed. And so this has become a hugely important issue, not only in the United States about how we do it, but in every country around the world. But I'll let you do the formal introduction.
Sure. So it is, of course, with great pleasure that I introduce my friend and colleague, Doug White, who many of you know. He's he's both an intensive care clinician and researcher, and also an ethicist who thinks both about conceptual ethical issues and also thinks about both empiric and experimental research in this area. And he has, he currently works at the University of Pittsburgh in the same department I work in. He holds the endowed chair in ethics in critical care medicine, and he runs our program on ethics and decision making in critical care, and is a professor of critical care medicine and translational science. And I would say that, just as Howard said, Doug has thought in an has brought incredibly rational and compassionate thought to an incredibly emotionally charged area about allocation of scarce resources, which initially was framed as ventilators, but with the recent suggestion that remdesivir may help, there's now a worldwide mismatch between potential supply and demand. And so Doug is going to speak about the fair allocation of scarce resources during this pandemic. Doug, over to you.
Derek and Howard, thank you so much. And hello, everyone. I hope everyone is staying safe. So as Derek and Howard said, I'm going to be addressing two JAMA papers, one that addressed the fair allocation of ventilators and ICU beds, the other that addressed the fair allocation of antiviral medicines during the COVID-19 pandemic. And, you know, honestly, the first time I think many intensivists in the world got a really clear view that scarcity of ventilators is a real thing in the West was the JAMA Live interview that Howard did with Professor Ciccone now a little bit more than 2 months ago. And I watched this live at the time, and I remember when Professor Ciccone talked about just the unbelievable volume of patients with acute respiratory failure coming in, and essentially, 50 patients a day to a single hospital in need of a ventilator, the kind of numbers that many of us never have seen anything close to in a single day. And so, I think it drove home the reality that scarcity of ventilators for people who will die without them is something that we may need to face. And so we published about 3 weeks later a framework in JAMA for rationing ventilators and critical care beds. And this framework really dated back to work that we started in the H1N1 pandemic in 2008, 2009, largely in response to the existing professional society guidelines at the time that were published in CHEST by the Task Force for Mass Critical Care. And the framework that they published, and this is a group of friends and colleagues, so I respect and agree with the vast majority of things in this document, but one of the things that I really struggled with, and a number of colleagues struggled with, was that the rationing approach started by excluding large groups of patients from access to ICU care. So patients with cognitive impairment were excluded, patients with neuromuscular disease, patients with metastatic cancer, even patients with moderate but not terribly severe heart failure were excluded from ICU access. Yet patients with COPD on oxygen would have been excluded, and patients who were greater than 85. And I think many people looked at that and said, these are concerning from a fairness standpoint to simply exclude people. And in the United States, we have recently had a very big uproar around the state-issued guidance from states like Alabama that essentially do a similar thing in which they recommend not offering mechanical ventilation to patients with, and these are their words, severe mental retardation, moderate to severe dementia, class 3 or class 4 heart failure, or again, COPD requiring home O2. And I think there are some real ethical concerns with using diagnoses to exclude patients from access to ICU care. First, I think it's really the wrong tool for the job because most chronic disease states are not sufficiently predictive of a poor prognosis to reliably exclude patients. And for me, the cleanest example of that is imagine a 50-year-old patient with moderately severe heart failure who's admitted not with a CHF exacerbation, but with an opioid overdose. And all he needs to survive is, 7 or 8 hours of mechanical ventilation and some Narcan, and he'll walk out of the ICU the next day. According to these existing guidelines, that patient would have been excluded from access to ICU care. Second, I think this approach sends a concerning message that there are just some lives that are not worth saving. And then finally, using these broad exclusion criteria violates a fundamental principle of public health ethics, which is to use the least restrictive means possible to accomplish the public health goal. So if there's a less restrictive way to do this, we should. And so we, in the framework in JAMA that we proposed, we first outlined what we think are 5 points of general agreement. And I'll just run through those quickly. The first is that rationing of ventilators and ICU care should be considered the option of last resort. And hospitals have a strong ethical obligation in a public health emergency to first do everything they can to increase their hospital's ability to care for more and more critically ill patients, and also to cooperate regionally to transfer patients from more busy to less busy hospitals. Second, during an emergency, there needs to be a shift in focus to population outcomes rather than solely on what individual patients would choose for themselves. Third, a triage officer, not the bedside clinician, should make these triage decisions. And this triage officer needs to be very well trained, both in the allocation framework and also in things like implicit bias and disability rights to avoid discrimination. Fourth, there are a variety of characteristics that should be viewed as irrelevant when making triage decisions: gender, race, ethnicity, religion, disability, perceived quality of life, citizenship, and social connections are among those things. And then finally, triage will almost certainly involve not only the initial triage decision about who gets a ventilator, but also re-triage and the notion of withdrawing life support from patients with a poor prognosis to provide it to patients who are much more likely to survive. Clearly an ethically and emotionally challenging thing, but one that is necessary to maximize population outcomes. All right, so then what about the substantive criteria to determine who should get an ICU bed? And I want to start by just pointing out work that Lee, Bittis, and Daugherty at Johns Hopkins did in the 2010 to 2015 time period. She engaged a large group of citizens in the United States and actually, in a very careful, deliberative, democratic way, took to them the question of which principles should guide allocation. And essentially what she found is that there were four main criteria that citizens believed should often be used in allocating scarce resources. Who's most likely to survive the current illness? Who's likely to live longer, which is to say patients who don't have an end-stage condition that will kill them anyway. Interestingly, patients who have lived through fewer stages of life, which is to say giving some priority to the young compared to the old. And then also giving priority to essential workers, that not only clinicians, but also individuals who maintain public order, work in food services, other essential businesses during an emergency. And I think really importantly, the overwhelming majority of patients rejected a simple random lottery as the way to distribute scarce resources. So the ethical framework that we outlined involved essentially balancing our commitments to social justice while appropriately storing scarce resources. And what that means operationally is that all patients should be given a chance to receive treatment, which is to say no exclusion criteria above and beyond the criteria we already use to say a patient is, for example, too sick to benefit from ICU care. Second, to ensure that all patients receive an individualized assessment rather than, for example, looking at a disease itself and making a judgment about their prognosis based on that. And then third, it's important to take proactive steps to diminish the impact of social inequalities that negatively impact patients' outcomes. And I'll say a bit more about this at the end. So the substantive criteria that we recommended are saving lives, so maximizing survival to hospital discharge, with some attention also to duration of benefit and selecting patients who are not expected to die in the near term from a chronic condition, and then also giving some priority to essential workers and to the young. So this is a framework that involves multiple principles, and you can imagine that sort of combining them into one allocation strategy could be quite difficult. And what we proposed is a multi-principle point-based allocation system with the two main criteria being saving lives and saving life years. And the way we specified both of those criteria were first looking at the patient's prognosis for hospital survival with a validated severity of illness score. And here we use the SOFA score, but we don't necessarily recommend it. And I think there's increasing data to suggest that it may not be adequately predictive of outcomes. But this is just illustrative to say patients are grouped according to their SOFA score and given points on a 1 to 4 point scale, with fewer points being higher priority patients. And then second, for saving life years, we specified that as the prognosis for near-term survival. So if patients have a disease that is associated with death within a year, they get 4 points. If they have a disease where death is expected within 5 years despite successful treatment, they get 2 points. And what this yields is a score on a 1 to 8 scale, with lower scores meaning higher priority. We also proposed that there are two tiebreakers. Essential workers could either have a point deduction, so get somewhat heightened priority, or the essential worker status could be used as a tiebreaker. And as a tiebreaker, we proposed life cycle considerations, which is to say some priority going to younger patients compared to older patients, not because of social worth, but because the young are the worst off in the sense that they've had the least chance to live through life stages. And I should just point out that the full allocation framework that we developed can be reached here. It's an appendix in the JAMA paper, and we give much more detail on these considerations. So this framework, after the JAMA publication, was relatively rapidly adopted and now has been taken up as the state guidance in California, New Jersey, Massachusetts, Pennsylvania, Colorado, and Oklahoma. So I think, you know, a real tribute to JAMA for disseminating the ideas. All right, shifting gears. Last night, JAMA released another really important paper, an ethical framework for allocating scarce inpatient medications. This is by Colette de Jong, Alice Chen, and Bernard Lowe at the University of California, San Francisco. And there are many similarities in the two frameworks for allocating ventilators and ICU beds, as well as inpatient medications. This is, as Derek and Howard already alluded to, incredibly timely because the Gilead CEO has released remdesivir broadly, and many hospitals are now both trying to get doses and trying to figure out how can we allocate this fairly. I just want to flag that remdesivir is merely an example of scarcity. There are likely other therapies that will come online in the coming months, hopefully will come online in the coming months, including convalescent serum and monoclonal antibodies that we expect will also be scarce for a time. And so the ethical goals that De Jong and colleagues outlined are here. There were 5 main goals: prioritizing saving lives, saving those with a good near-term prognosis, prioritizing essential workers, avoiding discrimination, and mitigating health disparities. And I want to just drill down on 2 of these to end. So prioritizing, or what do they involve for strategies to save lives? Well, first, they recommend that during periods of shortage, that use of the drugs should be restricted to patient populations where the efficacy is proven in the RCTs. So really sticking very close to the inclusion and exclusion criteria. Second, avoiding compassionate use for other indications, because these indications outside of what's been proven are likely to not be as effective to what has been proven in the RCT. And then relatedly, the authors strongly encouraged authors to not use anecdotal evidence to prioritize within the trial populations. And the logic there was that overall predictors of prognosis from COVID-19 may not actually predict the efficacy of a new drug, which is to say, we may as intensivists have an impulse to say, boy, my patient is critically ill with 2 organ failure. Clearly, they're going to benefit more than the patient on high flow nasal cannula, and I should give them the drug. But there are no data for that right now. And I think we need to wait for those subgroup analyses before we start to try to make predictions of who's going to be most benefiting of the drug in the subgroups. All right, so on to this last question of strategies to mitigate health disparities. I must say that this is a really controversial and important point. In the paper, De Jong and colleagues articulated 2 ways to do this. One is prioritize essential workers, but construe that category very broadly to mean not only doctors, nurses, respiratory therapists, but also the full chain of people who are involved in maintaining social order during an emergency. So people who work in retail, who are in maintenance and sanitation, people who work in restaurants, all of these people should be prioritized. And it's worth noting many of them are persons of color. So this is a kind of an indirect way to mitigate health disparities. They also explicitly noted that triage teams should be trained in techniques to avoid discrimination based on gender, race, ethnicity, perceived quality of life. And this is really where they stopped. But I would just like to point out that if we're truly going to mitigate health disparities, we actually are going to need to prioritize hard-hit groups. And some of the hard-hit groups are listed here. Latino and African American patients are dying at twice the rate of white patients. So this is a true health disparity. And if we're to address this, we need to think carefully about how. And I'm just going to end by showing you sort of a thought experiment. Let's say that 50% of the patients that you see in your ICU with severe disease are white and 50% are Black. You might say, well, listen, the fairest way to treat these patients is simply to give half of the scarce drug to the white patients and half to the Black and Latino or Latinx patients. If you did that, you may be missing a really important part of the epidemiology of disease, which is to say that 50% of cases arising from Black and Latinx patients is coming from a small proportion of the population. Let's say it's 25% of the population is Black and Latinx, but they're accounting for a disproportionately large number of cases of severe disease. So if we're truly to try to remedy what appears to be a large imbalance in deaths by race and ethnicity, we actually will need to take a proactive step that probably looks something like giving some extra priority to treating Black and Latinx patients, such that we can try to diminish the disparities in death rates across racial and ethnic groups. And I'm going to end there. These are the 2 papers that I discussed. And then the third reference here is the model hospital policy from the University of Pittsburgh, and it's available at that website. Thanks very much.
Thank you, Doug. Wow. So you do bring up many key issues. Let me start with just a couple that reflect things going through my mind, along with also some questions that are coming in. So a couple of things. First of all, I remember Robert Brooke from RAND talking about when he served on an NHS panel that was put together by the British government in the late 90s or 2000s to talk about how they would spend a finite number of healthcare investments in improving the NHS. And they decided to prioritize investing in things that would narrow disparities ahead of things that would improve health for all. So in other words, if an intervention helped everyone but didn't close the gap, that would be assigned a lower priority. And that seems similar to an issue you're bringing up here, where you might actually, while, for example, white individuals might benefit from remdesivir and the whole population would benefit from an evenly distributed policy, you would actually favor a policy that might weight towards those who have historically been on the receiving end of greater disparity. So that's one issues to ask you whether you think this actually ties to sort of larger framing issues about how one invests all healthcare dollars. And the second question, sorry, go ahead, and then I have a related question.
Let me answer that one first. Yeah, I think you can actually, you don't have to call on historical injustices in this case to say we need to prioritize hard-hit communities. These communities are being hard hit now. So this is not, for example, reparations for past injustices. This is, we're looking at populations of patients and seeing that there are groups that are disproportionately dying. And so if we are to try to have fair outcomes across society, we need to prioritize treating those groups so that the death rates begin to look a little more representative of the population.
Right. So that's very utilitarian and pluralist. It'd be interesting if everyone agrees with that, but it's interesting because it might be an implicit social value, but people might not have actually thought through ahead of time what the consequences are.
If I could say, Derek, this is a classic tension in distributive justice, right? The trade-offs between efficiency and equity. You have utilitarians on one side and egalitarians on the other, and they have been fighting for centuries. And I think that fight continues. What we've proposed is something of a hybrid between maximizing the public good and prioritizing lessening disproportionate outcomes.
Let me ask a slightly narrower question that gets very much to a comment made in last night's viewpoint. They make the point that you shouldn't consider compassionate use for groups that were outside the groups that had been studied previously in the trial because there's less likelihood that it would be beneficial. But some people are excluded from trials for not necessarily for efficacy reasons. So, for example, prisoners are not included in the original trial, but presumably they would be candidates for therapy, or?
Yeah, so I think it's really important to draw a distinction between clinical criteria to enter a study and sort of the research ethics and research machinations. So, for example, if patients are excluded from a trial not on clinical grounds, but because, for example, they don't speak the language of that country, then that's an irrelevant consideration in my view. And those patients, I think a reasonable triage officer would look at that and say, whether or not they speak English or whatever language of the country they're in is irrelevant.
And if they were pregnant?
Well, pregnancy brings up different issues because some of these drugs, we just don't know whether the drug is particularly harmful or teratogenic. And so I would say that needs to be a somewhat individualized judgment about the safety of the drug.
So Howard, before you leave, it's Howard. You started by saying this is going to be the first of many, many struggles around rationing. Monoclonal antibodies, I think people in the U.S., there's some coalescing around that may be what becomes available first on a large scale. Convalescent titers or convalescent serum, if it plays out and is successful, and the vaccine. in the US, we're not going to have 325 million doses of vaccine. Do the same ethical principles that Bernie and his colleagues and you have written about, do they apply in a similar way to each of these potential preventive therapies?
Well, so it's a really good question. I think the criteria for ventilators, ICU beds, and inpatient medicines are quite similar. I think we may see some very different allocation criteria for vaccines once they're developed. There may well be a priority for the patients who are at highest risk of death. So, in some of these frameworks, those at the very highest risk of death are not getting prioritized for inpatient treatments. That may not be the case for the outpatient setting, where we may say, listen, for vaccines, we want to prioritize those who are infirm, those who are of advanced age, and those who have chronic conditions. So, and from a justice standpoint, it really is critical to consider the particular therapy in question and what are the criteria that are most relevant to that therapy.
So, Doug, let me see if I understand. When you say prioritizing, you don't mean 100% allocation. You mean weighted allocation, but it's still a lottery. And so if there's only 10% of the need could be met, even though some groups might get 15% access and others might get 5% access, many people will not be getting it. And so do you see this then as an opportunity to actually learn? In other words, for someone to be in the lottery, should there be an agreement that information about what happens to them, regardless of whether they get the therapy, should be included in a national database? It's essentially a large randomized trial.
Yes, exactly. So what I'm on the advisory board for the state of Pennsylvania, and we are trying to convince the state that the allocation of drugs, let's say that there are 100 doses and 1,000 patients who want it. That means each patient has a 1 in 10 chance to get the drug. In the allocation lottery, which would be a weighted lottery, we propose that all the patients should be followed, because this, as you said, this would be a natural experiment in the sense that we would have the ability to look at, for each of these scarce therapies, does it actually help in real world effectiveness outcomes? And this is a way to learn as we go, and also to give everyone a chance to receive the scarce therapy.
Okay, so I haven't been dinged yet by ESICM, but looking at the time, I know we have to be running late. So I think we should wrap. I have to say, this pandemic has put all of us in a place that none of us would ever have wanted to have been in, both for ourselves, for our loved ones, and for our patients. But it's also been a moment where we've seen much of the goodness and just the strength of character and devotion to duty among many of our colleagues, our colleague researchers, our colleague clinicians. And this session was one more example of it. For me, it was a great pleasure to hear the thoughtful and earnest way in which Doug and the other two speakers spoke. And so on behalf of Howard and myself and the entire JAMA family, we want to thank ESICM for this opportunity to host this little session for the last hour. Final words, Howard? Or?
Stay safe. And, I've never been more proud to be a physician and a provider than I have been in the last few months. It's an extraordinary profession. And I want to thank our readers, our authors, and our peer reviewers.
Thanks.